I'm another David. I'm a Professor of Public Health and Policy at the University of Liverpool, and I lead Liverpool's Health Inequalities Policy Research Group. I'm a paediatrician by training. I've then gone into public health, and I work as a consultant in public health at Alder Hey Children's Hospital alongside my academic role. So this is William Farr. I work in the Farr Institute in Liverpool, and as many of you know, Farr set up the system for collecting data on deaths in England and Wales. And he did some of the first social epidemiology. So he contrasted death rates across different parts of the country and calculated in 1864 that there were 65,000 children's lives lost unnecessarily in England. And then this is what he wrote in a government statistical document, a Registrar General's report. So he took the data and wrote about the annual sacrifice of children's lives. He said that the children passed through the fire to Moloch scarcely incurred more danger than is incurred by children born in several districts of our large cities. A strict investigation of all the circumstances of children's lives might lead to important discoveries and may suggest remedies for evils of which it's difficult to exaggerate the magnitude. Unfortunately, in public health, we're still writing grim reports about health inequalities and trying to document the lived experience of children and young people. I've led the Child of the North initiative with Kate Pickett, which has been about children's health and looking at what's happened over the period during the pandemic. And we launched this report in Parliament as part of our all-party parliamentary group at the start of this year. This was about the cost of living crisis affecting kids, particularly kids in the North. And we outlined routine stories of adversity faced by children growing up in the sixth biggest economy. So kids, parents using watered down evaporated milk in bottles because of the price of formula, children turning up to school without shoes, a school in the Northeast that routinely used its budget to buy shoes for kids, young people families unable to attend medical appointments because of travel costs, parents terminating wanted pregnancies because they can't afford the costs of a baby. And working as a public health doctor in my beloved city of Liverpool, this is the kind of challenge that we face. The plot shows what's happened to infant mortality in Liverpool, and we see a large chunk of the population born into poverty, and a large group of children facing obesity and mental health problems very early in the life course. So in this talk, I want to talk about inequalities and the role of social adversity in generating those inequalities. So I'm going to talk a little bit about pathways and show some of the data, some of the work that we've done on pathways to health inequalities. And then I'll turn to the policy experiments in investment in children and disinvestment in children that we've seen over the last 20 years, and then think about what can be done. I guess it's difficult to put a positive spin on some of the numbers in terms of children. We kind of, I don't know if people like footballing analogies, but we kind of think of ourselves as a Premier League type country. But when it comes to children's health, the UNICEF has suggested that we rank 27th in OECD countries along a number of axes. You could choose many metrics to illustrate this: mental health, obesity, asthma. We continue to drop down international rankings in terms of children's health. And one of the reasons that we do poorly on average is because disadvantaged kids in the UK fare particularly badly, and there are large inequalities in children's health outcomes. So if you contrast, this is Kensington in Liverpool, this is Kensington in London. If you look at the difference in life expectancy between the poorest tenth of areas and the richest tenth. There's over a 10-year gap in life expectancy at birth for children. There's over a 20-year gap in healthy life expectancy. So these are health inequalities, as you know, and we can assert a number of things about these inequalities. First of all, there's nothing natural or predetermined about these differences. They're a consequence of how we organise society. Secondly, they're profoundly unjust. And thirdly, we can do something about them. We can do something about them through the organised efforts of society, which is what public health is all about. And broadly speaking, we know what generates inequalities. This is the seminal Whitehead and Dahlgren and Whitehead model of the social determinants of health, the main influences on health. Margaret was the Duncan Professor of Public Health before I took up the role, and it's clear that it's inequalities in the distribution of the main influences on health that lead to inequalities in health outcomes. And these drivers, they're similar whether you're looking within Liverpool, within comparing the north or south, or within Cambridgeshire. The processes that generate inequalities are similar, and they're due to differences in power, in exposure to health damaging factors, in differences in exposure to health protective factors, and especially the factors that give all children the best start in life. And I guess while we know less about the processes that lead to inequalities in the distribution of these determinants, and that takes you to analysis of power structures. It takes you to issues of racism and discrimination. It takes you to issues of hidden processes. We've been hearing about some of those processes during the COVID inquiry, and how the decisions made in the corridors of power have profound implications on population health. It's also due to explicit decisions made about resource allocation across different parts of the country, and I'll speak to some of those. So I'm going to turn now to some of the work that we've done on pathways and mechanisms. I guess the picture here shows the intergenerational transfer of social disadvantage, where adult social and health disadvantage in one generation affects the conditions into which children are born. So we know the importance of antenatal health is critically important, early child development critically important, which affects the distribution of child health, which then affects the distribution of learning, and thus you get the transfer of disadvantage to the next generation. In a bit more detail, you can see this plot here shows, this is based on the Finn Diedrichson's conceptual model, which shows how differential exposure and vulnerability to risk factors and the differential consequences of ill health lead to inequalities across the life course. So being born poor affects exposure to housing conditions, to access to early learning, to books, to all of the things that lead children to develop healthily. It affects exposure to psychosocial risk factors, adversity, family breakdown, exposure to violence within families, and of course behavioural factors, exposure to environmental tobacco smoke. All of these things affect children's health and the patterning of children's health. And then you have the process of differential social consequences, whereby being poor and having poor health disproportionately affects the risks in terms of education and socioeconomic status in adulthood. So I've asserted a number of things. I'll turn to some of the data. There have been a number of focusing events around children's health over the last couple of years. So this boy, Awab Ishak, the coroner suggested that he died because of exposure to mold. Ella died of asthma due to, again, the coroner said, due to exposure to air pollution. Asthma continues to be one of the major child health conditions that we focus on. And this is an analysis where we've looked at the mediating pathways. So how does being born poor affect exposure to a whole range of risk factors to asthma? And then how does that go on to explain inequalities in the type of asthma, in chronic asthma, the type of asthma that transitions into adulthood and affects children affects adults across the life course. And we were able to use rich data from the Millennium Cohort Study to unpick that simplified directed acyclic graph, which is shown there. So let me show you some of this is data from Millennium on exposure to smoking in pregnancy, showing an axis of disadvantage against the prevalence of kids' exposure to smoking during pregnancy, highly socially patterned. You see the same patterning in terms of exposure to environmental tobacco smoke in the first 3 years of life. You see exactly the same patterning when it comes to not being breastfed, another risk factor for developing asthma. And if there's good data on damp and housing conditions in Millennium, and again, profoundly socially patterned. And then when you do the causal mediation analysis, we show that being born into social disadvantage doubles the risk of kids developing persistent asthma. And around two-thirds of that risk, that excess risk, is explained by perinatal and environmental factors that we can instrument and capture in Millennium in the first 3 years of life. Again, focusing action on the early years. My mate's Ian Sinner, who's a respiratory paediatrician at Alderhay Children's Hospital and a professor of paediatric respiratory medicine, suggests there's not much. He spends less of his time thinking about the treatment of complex asthma with new disease-modifying drugs, and he's developed a tool whereby respiratory paediatricians can write to landlords to complain about environmental conditions that children are living in, arguing, like Marmot does, that there's no point in treating people and sending them back into the social conditions that caused their disease in the first place. I'll talk through now a couple of analyses that we've done looking at the social patterning and the burden of exposure to different types of adversity in Millennium in UK kids, with a focus on parental mental health problems, domestic abuse and violence, and other aspects of childhood adversity. So first of all, again, this is data from Millennium Cohort Study, shows the prevalence of poor parental mental health and poverty measured cross-sectionally by age at the different waves of the Millennium Cohort Study. See roughly in the blue bars, the big bars, that's exposure to relative child poverty. Around 30% of kids regularly exposed to relative child poverty. And you can see the prevalence increasing a little bit. You also see a clear increase in the prevalence of parental mental health problems. Again, these exposures are very common. They're common, and what we did in this analysis is develop latent classes of exposure using all the data up to age 14 and looking at the trajectories of exposure to a range of adversities. And what we see in the analysis is that you see persistent trajectories, actually. Most of the trajectories we see are around persistent exposure to various things. And in the analysis, 43% of kids fall into the low exposure group. So around 40% of kids, low exposure to adversity. 23% of children in Millennium are always in poverty every time we see them every 2 years. 12% of kids always exposed to mental health problems in the family. And then 11% of kids exposed to both poverty and persistent mental health problems. And then other groups persistently exposed to alcohol misuse, a smaller proportion exposed to domestic violence. And then we looked at the impact of those trajectories on a range of health outcomes, alcohol experimentation, cognitive disability, drug use, obesity, and mental health problems in the next generation. I won't go through all of the results, but you see that most of the adversities have an important impact on children's health outcomes, but particularly the cluster of kids who are 10% of kids in the UK who are in poverty and their parents have mental health problems. They have 6 to 8 times the odds of developing mental health problems themselves. And then we were able to calculate population attributable fractions, again asking the question, how much of the burden of poor ill health in kids who are just becoming adults in Millennium Cohort Study could be prevented if we reduced exposure to those adversities to the level of that 40% of kids who are in the low adversity group. And what the analysis shows is that potentially you could eliminate half of the burden of mental health problems and a significant chunk of the burden of cognitive disability, obesity, etc. So that's data from the UK. I work at the University of Copenhagen, where, as David said, they've got great linked data in the Nordic registries. And we were able to do some of these studies using population level data. And the reason to use Danish data is that they have the longest follow-up. So in Denmark, they've got registry linkage going back to the 60s. So you could follow up the whole population and try and instrument different aspects of adversity and look at the impact on health in adulthood. So that's what I'll show now. And that we wrote an editorial about the focus on ACEs, the so-called adverse childhood experiences. But you know, what about the issue of socioeconomic conditions structuring exposure and vulnerability to ACEs, and how does that affect morbidity and mortality across the life course? So that's the type of question we were trying to unpick in these analyses. In this paper, we looked at 1 million children, so the whole population of kids in Denmark, followed up from 1980 onwards. And so it measured every year in all of the children. We're able to capture different dimensions of adversity. So material deprivation, being in poverty, parental long-term employment, stressful events in the family, loss or threat of loss. So parents dying, siblings dying, important diagnoses of disease in the family, and also aspects of family dynamics. So kids being taken into care, parental mental health problems, parental drug abuse, and parental separation. So we captured all of those every year up to age 16. First question is, are they socially patterned? And yeah, as you'd imagine, if you're more disadvantaged, you're more likely to have more of those adversities. And then we used the same approach that I described earlier, a group-based multi-trajectory model to compress all of that data up to age 16 into some latent classes, which I don't know if this... So I'll just talk you through this. So in Denmark, again, using all of those domains of adversity, about half the population have low levels of deprivation, stressful events in the family, adverse family dynamics. About 20% of kids are transiently exposed to poverty when they're born. What does that say? 13% are always in poverty in the Danish context. There's a group there that have lots of these high levels of stressful events in the family, loss or threat of loss. And then there's a group, about 5% of the population, that has high and increasing levels of all of those adversities. And then we used those exposures in a Cox regression analysis, first of all, looking at mortality. So we measured the exposure to age 16 and then looked at mortality in the population. And this is what the analysis showed. This is the background. This is cumulative risk of dying. This is the background reference population, the low adversity group. These are the kids that are transiently exposed to poverty. 20% of kids in Denmark transiently exposed to poverty. I'm going to use relative risk measures, I'm afraid, because I don't have the absolute ones immediately to hand, but you have double the risk of dying in Denmark if you're transiently exposed to poverty. 50% hazard ratio of 1.5, 50% higher risk if you're in this group. This group has double the risk of dying, a hazard ratio of 2. So if you're in persistent poverty or your parents die in childhood, you have double the risk of dying. And then this is the high adversity group with multiple clustered adversities, hazard ratio of between 4 and 6 in terms of risk of death as the population ages. And what are these kids become young adults dying from? Well, the things that you'd imagine in this population: increased risk of suicide, particularly accidents, but also cancer. And we've gone on to look at, there are now analyses looking at cardiovascular risk, and we see a similar pattern for cardiovascular risk. We're looking at major mental health problems. We did another couple of analyses using these data. In this analysis, looking at patterns of hospitalization, so patterns of hospitalization that mirror those adversity trajectories. So this is what hospital admissions look like generally in most populations over the life course, and in Denmark. This looks at, so you're more likely to use hospitals when you're born, and as you get older, this line goes up if you saw it continuing. But you see a similar pattern. You see that adversity, you see a graded response in terms of those adversities. So adversities drive high levels of health utilization in the early years in Denmark and in early adulthood. And if you look in more detail at the paper, it's broken down by different ICD codes. And you can see here, this essentially shows the intergenerational transfer of mental health problems, where these are the kids who are exposed to high levels of adversity, go on to develop mental health problems and be diagnosed. One of the other interesting findings was about respiratory conditions. So the high adversity group, the kids in the high adversity group have very high levels of admissions in the first 3 years of life due to respiratory conditions. So again, adversity linked to high levels of respiratory admissions. All of this suggesting that significant short-term cost savings potentially from addressing some of these issues. And then finally, we answered the question, to what extent do those adversities explain inequalities in mortality in adulthood? So the Kensington differences, those equivalent inequalities in Denmark. And to cut to the punchline, the limited number of adversities that we could instrument in population level data measured up to age 16 explain half the social inequality in mortality in the Danish population. This is before you even get on to measuring the major lifestyle factors that we get very exercised about in adulthood. So a large chunk of the action going on in children, which is, I guess none of this is anything new in terms of what we know about the importance of the early years and the fact that childhood social conditions cast a long shadow over the rest of the life course. But it was the first time it's been shown in a whole unselected population cohort. So I'm going to change track now and talk a little bit about the evidence from the UK policy experiment. So this plot shows, it's from the Institute for Fiscal Studies, and it shows child relative poverty, and you can see that relative poverty in kids came down dramatically and then was predicted to go up dramatically, and that's indeed what's happened. If you look at the actual data, these were IFS predictions based upon the policies that were implemented. I guess another thing that you note here is that poverty in pensioners remained absolutely stable over a period of great fiscal turmoil. So you can implement policies that protect particular social groups. Why did poverty drop like that in children? Well, it was part of the English health inequalities strategy. And we've written in this book with Gordon Brown and Jacinda Ardern about what happened during the English health inequality strategy. So this was part of New Labour's action on health inequality. Is widely regarded as one of the world's, well, probably the world's largest experiment in trying to tackle health inequalities. What did it involve? Well, targets. So there were targets around life expectancy and infant mortality. It involved resource allocation. So a significant amount of resource was channeled, particularly in the health system, to disadvantaged areas. Focus on area-based regeneration, tax and welfare changes, child tax credits, a big focus on reducing child poverty. Sure Start was set up. And then there was a technical focus on primary and secondary prevention of adult chronic disease. And Ben Barr, my colleague in Liverpool, was involved in looking back retrospectively. Certainly the strategy didn't immediately hit its targets, its predefined targets, but this is probably one of the most important analyses that shows this shows inequalities in absolute and relative life expectancy increasing prior to the strategy, decreasing during the period of the strategy, and then this upturn. And another analysis by Robinson and colleagues has shown a similar pattern with infant mortality. Tom here, you've been involved in the systematic review of some of this evidence, which shows fairly consistently that the strategy had a clear impact on health inequalities. John, sorry. But hard-won gains can quickly be undone, and indeed, after the financial crash and from 2010 onwards, we saw a reversal. We saw a reversal of those policies, and child poverty has now risen to the levels that it was right at the start of the English health inequality strategy. And the tax and welfare benefit changes that led to rising child poverty happened at the same time as large cutbacks to public services. This was analysis we did in 2011, just looking at the proposed distribution of the cuts to local government funding. This was Liverpool at the time, which was the most disadvantaged local authority. The biggest cuts to its budget. There were systematically bigger cuts to areas in the north compared to the south. And we've done a lot of work on pulling the data together and following the money. This is what's happened to prevention for children. If you believe that prevention is important in those early years, this is what we did this shows the spend on Sure Start and early years prevention over the last decade, and shows that there were much bigger cuts to prevention in the most disadvantaged areas. This is Yoko Ono opening the Children's Centre around the corner from where I live, the school that John Lennon went to. £1 million investment, and almost as soon as it was opened, it was under threat of closure. And Yoko Ono was very instrumental in our advocacy locally in trying to use the evidence base to keep some of these centres open. So we saw rising poverty, we saw cuts to local government services, and then we started to see cracks in the system. Food poverty didn't exist 10 to 15 years ago. It wasn't an issue. Now it's very much on the public health agenda. In this analysis, we showed how the rise in food bank use was driven by high levels of social disadvantage, and particularly by benefit sanctioning. We saw a rise in admissions for malnutrition, food poverty, a public health emergency. We had Sally Davies. Is she just around the corner now in Trinity? We had Sally Davies talking about rickets making a comeback, and then we started looking at child mortality and wrote about the risk of child health unravelling in the UK. This shows infant mortality by deprivation quintile in the most and least deprived. And infant mortality has come down continually, almost since the age of 4, given one or two shocks around wars, etc. We see a continual reduction in infant mortality. We saw infant mortality rise on average for the first time, and it rose solely in the most disadvantaged groups. This plot shows it in a little more detail. And then we went on to do an area level analysis to look at how changing poverty at area level affected changing infant mortality in this paper, where we show, using fixed effects, quasi-experimental approaches, we show a causal effect of child poverty on rising infant mortality. So 600 excess infant deaths over a period of 3 years related to rising levels of child poverty. If you want to know, I presented at the COVID inquiry a few weeks ago, we presented a report on child health inequalities and what was happening prior to the pandemic. And it's pretty consistent across numerous children's health outcomes. You see it for infant mortality in England. This just shows, the black dotted line shows the inequalities gap going into the pandemic. We see a similar picture in Scotland. You see a picture of inequalities narrowing and then starting to rise as we go into the pandemic. And we've documented that for obesity and for a number of other children's health conditions. Another very concerning indicator or trend has been around children entering care in England. This just shows the numbers of children in care over time. There's a very nice analysis in Lancet Public Health looking at long-term trends in child maltreatment by colleagues, where they look at child maltreatment registrations in the social care system. And I don't know the extent to which people are aware of the huge number of children entering care, particularly due to neglect and emotional abuse, and the fact that we're seeing very steep rise in those reasons for children entering social care in England and Wales. There's real concern that we could see 100,000 kids in care, and we've looked into the inequalities angle to what's been going on. And it was one of my PhD students who just done a PhD, Devara Bennett, looked at inequalities in care entry. This was work through the School for Public Health Research, and we showed that inequalities in kids entering care were narrowing, and then we saw a rise in inequalities in care entry in children. And then we tested two hypotheses. We tested the hypothesis that austerity measures had led to cuts to local authority preventative budgets, which had led to children entering care, and also that austerity had led to an increase in child poverty, which is a risk factor for adversity, which led to care entry. And indeed, these analyses show that both of those pathways are clearly at play, but by far the most important is the child poverty story. And in this analysis, we suggest that almost 10% of care entry, just over a 5-year period where we've got good data on child poverty, that's an extra 10,000 children entering care as a result of rising child poverty, again using a fixed effect type analysis. And the short-term cost of that, 1.4 billion, that's just the corporate cost of looking after those kids. Now, this story is important not just for children, obviously for children themselves, but it also plays into the broader public health prevention agenda, because in many areas, and in Liverpool particularly, we're seeing a lot of the budget that's spent on prevention is being spent on looking after those kids in the care system. So acute pressures and it's a microcosm of the system where we're seeing rising adversity leading to increased health and social care use, which is leading to further cuts to prevention. That's one of the cycles that we need to break out of at the moment. So pre-pandemic, The Lancet said that Britain is broken, poor child health proves it. We presented evidence to Philip Alston, who's the poverty rapporteur. You'll have read that the poverty rapporteur is in town again this week and fired a warning shot yesterday saying that things have got worse. But Philip Alston was very clear and said poverty is causing misery in the UK and ministers are in denial. And pre-pandemic, we wrote this in The Lancet regarding the discussion. I mean, I'm not going to talk about it, but life expectancy, as you know, was going backwards in poor areas pre-pandemic. And we wrote that we've seen rises in child poverty, homelessness, food poverty, and a deterioration in mental health. These have occurred at the same time as reversal of investment in public health services, with the biggest cuts in the most disadvantaged areas. It's time to acknowledge the elephant in the room, the underlying causes of these disturbing health trends in England, and to design appropriate policies to reverse them. Okay, so and we were all, lots of us were involved in discussions about what was going on with life expectancy, and then we got derailed because we had a pandemic. And we wrote early on that, invoking the Diedrichson pathway to health inequalities, that although the pandemic is caused by a virus, the inequalities it generates have the same social causes. And as in all crises lay bare fault lines across society, and our Child of the North report showed how children's inequalities were supercharged as a result of the pandemic. The Lancet wrote recently that COVID has been and still is a catastrophe for children, the biggest threat to children in our 75-year-old history. Policymakers and the international community have failed dismally to protect children and adolescents during the COVID pandemic. And we saw, this is from the Child of the North report, but using the NHS digital data on probable mental health problems, we saw almost a doubling of the prevalence of mental health problems in kids and almost a doubling of the absolute inequality. And as you've probably seen the plots for obesity, which I haven't shown here, which show exactly the same thing. We saw a doubling of obesity prevalence in 5-year-old children and a doubling of the absolute inequality over a very short period of time. What are we to do about some of these pathways to health inequalities? Well, I think at the moment, we're running without a roadmap to addressing health inequalities. We don't have an inequality strategy, and the government, this was a quote from a minister saying that the disparities paper, as we're now encouraged to call it rather than inequalities, the white paper on inequalities was pulled, and the reason for that was ideological. A minister said that the content was an affront to this government's view of what makes for health. I hope I've outlined some of the things that I think make for health in a population. And I guess some people say it's depressing to hear about adverse trends in children's health, but I'm an optimist because there's absolutely no reason why we need to have such poor children's health in this country, which drives high levels of poor adult health, which drives pressures on services, which leads to the stagnation of life expectancy that we're seeing at the moment. We've got strategies starting with the Sustainable Development Goals that focus us on the things that we need to address for population. Number 1, no poverty. Number 2, zero hunger. Number 3, good health and well-being, education, etc. Margaret always points out that similar points were made in the Black Report 40 years ago. A key focus on the socioeconomic conditions of children. We said the same thing similar things through Due North, through our Child of the North report. We summarised some of the evidence in this report for the WHO. I mean, put simply, systems need to act earlier. They need to act on time. They need to act together. Reducing child poverty is a prerequisite for addressing poor child health in this country. We need to invest in populations proportionate to their level of need. We need better data so that we can track and measure the impact of policies on health outcomes. And we also focus on rights-based approaches to advocacy for children. In terms of poverty, I mean, there's in the latest comparative data, that's where we are in OECD countries. We're above the OECD average for levels of relative child poverty. I do a lot of work in Denmark, half the prevalence of child mental health problems. We actually come in 27th for level of poverty. We come in 27th for the ranking of children's health. To some extent, you get in what you put out. Similarly for public spending on the early years, on early childhood education and care, we're way below OECD averages. Better data, we're in many areas. We're starting a new birth cohort in Liverpool, which will track the impact of kids born post-pandemic, post-Brexit, and will be hopefully like Alsbach. So we're just starting to recruit children to the cohort, and it's nested now within a population level data linkage cipher that was used during the pandemic to look at the impact of rapid testing. We've also been arguing from a rights-based perspective. If you read the UN Convention on the Rights of the Child, it's a beautiful document, and it suggests that children will enjoy special protection and have at their disposal services dispensed under the law and through other means, allowing physical, mental, moral, spiritual and social development in a healthy and normal way with liberty and dignity. And again, we've implemented working with UNICEF, a children's rights-based approach to thinking about how we organise services for kids in Liverpool, very much putting their voices at the centre of policy. So Alyssa went and presented to ministers when we launched the Child of the North report. We presented a lot of evidence. She talked about her personal experience of mental health problems during the pandemic and set off a chain reaction of ministers all trying to out-pledge each other in terms of what they would do to address some of these problems. So I'll finish there. I think it's baffling to me as a child health doctor that we allow an exposure as toxic as child poverty to wash over a third of the children in our country. And there's clearly a lot we can do to implement some of the findings of the research and the reports that have been documented over the last few years. Thanks for listening.